because we are transmitting live. So if I move the camera, I'll have to disconnect and move my phone.
Data we collected. There was a screening page tonight at the beginning. So we want to hear what you find in terms of pre and post when you did reaching. Was there any difference? Before that, you just hold your thoughts. Please.
Thank you very much. I know we are pressed for time, so I'm going to be very fast. From some of the things we've done before, we're beginning to understand that health is not a priority for young people. They have other priorities, particularly when you talk about HIV and AIDS. So I guess interventions that work are the ones that look at the total well-being, just like somebody has mentioned. So if you're going to use, what we call social direct, so that becomes like an in-room. But usually for young persons, health is not usually the first priority. I guess the second issue is for young people are not generic. So in other words, they are different in terms of vulnerability, so different in terms of behavior, and this are informed by several factors. So our ability to be able to categorize young people into these various blocks is also very, very, important. I guess one big problem also finding out, particularly for adherence and retention, is for those who got vertical transmission of HIV and AIDS, and their parents are yet to disclose. So for many of them, adhering is a problem. Now that they are adult and they are asking, why am I taking this? And most parents are not, telling them the truth. So they're telling them, well, you're taking it for headache, you're taking. So many times once they give them, they throw them away. So that is really one big problem, with adherence. Thank you.
I don't know whether it's like whether they subletted the OSS issue, but yes, we have OSS in the States, then being handled by ACUS. But now, there's still there's no integration per se between the OSS and SASCA. Like actually, for me, I don't actually know what happens at OSS in Enugu State. And that is a big issue. I've already, on my own, I visited the place. They don't know me, but I visited the place. They kind of introduced myself to them. I'm the SAPC, and people have been here for some months, and we didn't get to come to the Ministry of Health to identify. Then last time we did integrated mental supervision, collected by, I think anchored by NASCAP. We all went together. What is that there's no much integration, and being that the data, I as the SAPC cannot actually monitor the data or the cohorts as they do, as should be. The way it should be. So, for me, I don't have anything like any preventive, materials like condom or whatever, which I believe I ought to collect. If I have any, do harmonization, learn from them, and we work together. Okay. So that is the issue we have.
Yeah, just addition to what he said.
Okay.
Yes.
And also there are very, very few adolescent-friendly facilities. And they're coming to use the word kind of functioning. They might say they are adolescent-friendly, but are they actually functioning as that?
Okay. Over to you.
Thank you very much. Actually, I missed a point and you said it here. Actually, most of the things you explained now, you will see that it's actually that issue of coordination, that issue of what I call a bifurcated response. I call our HIV/AIDS response nationally, I call it a bifurcated response. Maybe the word is wrong, but I think then there might be so much need to have SACA different, SASCAP different, NACA different, NASCAP different. But you can see the intersection now. So many things now, like what he said, the OSS and then the SASCA. And then we are talking adolescent care now. And then there are so many preventive services within the adolescent care. So you see, SACA and SASCA definitely ought to be like this. Yes, but for me, actually, I would say that we're opportune for Kano that when formed by law, we were made to be one. So in Kano, there is no this bifurcation. Yes, it was made clear that, okay, this, what are we all after? HIV/AIDS. Okay, so we need a DG. That is what the Prof said, that state should have DGs and that same structure. And then, okay, if we have DG, and then there you said we should have SASCAP as a program manager. So why don't he come under this structure? And then we have a single structure, a single reporting line. I think that's what we have in Kano, with the DG, then the Director of Prevention, and then the Deputy Director of Prevention also doubles as the SASCAP program manager. And then the Director General report to the Commissioner, then to the Governor. So not just the Commissioner of Health, the law said 6 commissioners, but the health is the leading commissioner. You get it. So the law said 6. You know them. We all know women affairs. So I think if it's a weakness now, then it might be a strength when it was formed this way. But now it is time that we need to own these programs, and then we need to gather our strength into one place, and then it will give us more impetus for the fight. I think this should be considered in bigger forums. Prof, we are here. No, I'm saying Prof is here because we gave back these things. So
testing because it's a population that has high.
So I think I always say that we can actually that problem is not actually for us is never a weakness, it's a strength for Kano. So and I always advise other states to look at it from this perspective. If you can't have it by law, then you should have it by mutual understanding. Yes.
Excuse me, just still on
No, you okay because
because we are talking about
so that you don't feel like I'm talking. I'm telling you my own experience, and I'm advising that I'm sure for most states it's a weakness, but for me it's actually a strength.
yes.
For me it's a strength. If you like in Kano, write 100 letters to the governor or to the commissioner. By the time it comes to my table, I'll tell you that you actually succeeded in increasing the bureaucracy.
Thanks
Because
a lot
it
for
will
that.
gravitate down to that table. That is where action will start. Yes. So
Thanks a lot for that. I hear you clearly. I'll have those that came in a bit after we've started to introduce themselves, but I also want to what you said. Just like you mentioned, at that time, it was SACA was a multi-sectoral response. But increasingly, we've seen now that since the response is narrowing down to the health sector, and I like the fact that you preferred a solution. If it's not by policy, the policy to say SACAs and SACA should work hand in hand.
So the first place is awareness, and then we can start to come up with engagement services. Yeah.
So there are lots of ideas. We need to engage them. So you were talking about they are there. We know they are there. But we look the other way and tell that they are not there. It's one thing for them to try find, navigate, strategies to sort themselves. Now I think it was on us to engage the government to say, look, this is happening at different levels. So how do we help them? Because once they are aware that people at different institutions or levels are willing to meet them and help them, forget about tradition, culture, religion. Now it's happening, whether we like it or not. So how do we fix it? Once they know that we need to and you see lots of them coming out. Also, we need to cast into our own centers and really help workers. So you take a bath, you take all of them aside. What are we meant to do? How do we provide care for this family member? how do we sort it out? At this point, we need to wake up and realize no more pain and isolation. It's happening. So how do we tap into its levels of governance?
Okay, I just want to say one very important thing for sustainability, and that is the fact that our stakeholders, which are this set of people, should be responsible for their own. Is very important. If not, no matter what we do, we will still go back to square one. We continue to
want them to be incorporated.
What I mean is that
reorientation.
Yes, they need some reorientation in terms of what they can get and what they cannot get, rather than make it look like I am entitled to this. So if other adolescents that are not KPs are coming to clinic and they are sitting and getting their services, and these ones also should see that there's nothing special about
it's almost like them to sign a contract of secrecy. Okay, for instance, in my center, they said they come to the location of the article. We chose later when it's an open place, everybody comes. They said no, they won't come during the week. Said okay, Saturday. I said no, they won't come during the day. So am I going to come and is it like an occult something?
But the thing right now, why? The question is, why will they not? So that may be the issue. That may be the issue. Okay, please. Okay, now last question. Okay.
So as I was saying, you know, during this program, I was sending 100 naira. Most of us are complaining about them borrowing money and then it's swallowed by whatever system they are. So those kind of things, they are not sustainable. No, we should start thinking of how we can get them to become responsible.
Anyone can give me a strength, a weakness, an opportunity, or a threat. We're opening it up. Anyone has any thoughts about how we? Of course. Yes. I think that's a really great point. So we just focused on, not on all KPs, on all KPs. That's the opportunity. But we didn't do that, so the opportunity is that we need to. And so I have a question about it. 10 minutes? I got it. We're on it. So I have a question about that because you asked. So our strategy, and we talked about this as a team, was about using like social media platforms to engage. So we were able to use like Grindr. Could we use a similar strategy with female sex workers? Are there social media platforms that we could target? It would work for what?
So it would not work for, like, I would say the majority of the young people that actually like specific.
That's what I was curious. So our strategy that we use, so maybe the opportunity is different strategies to reach different, so maybe the opportunity is to devise different strategies to reach different KP populations. Because our strategy, we thought about it, but I was like, I don't know that it would work, you know? They're more visible.
For most times they don't agree.
So that I think would be so there's an opportunity like what to engage with female sex workers about what strategy might work to also get them. So. All right, we've now got 9 minutes or maybe 8 minutes left. Next steps.
Yes.
What should, well, that's like, what should, I mean,
Like what do we recommend?
Focus on the opportunity.
do people want to make specific recommendations about what eye care should do next? All right, lots of hands. Hand is going first. Expand to other parts of the country. Yeah.
But then we understand that some of these facilities, they have support platforms and all these things. But then we understand that they are also growing organizations that provide support that is support for things that we want to do. Okay. So what
I'm saying is that we focus on the top 95
should focus on the viral suppression.
For them as navigators, they go through a lot to them, and it's like care. That third part, which is the suppression part, is not really focused on.
So you agree with that stigma is still an issue in HIV settings. Last week we had a course to interact with here at Matos to receive information on some of their concerns. And the company virtually 90% of the short stigma, and it has the potential to really take away the effort we are making in terms of achievement. Most of the interventions we are doing. So going forward, I would like to see more innovative approaches on how to deal with stigma. That is why I think looking at photo voice intervention for stigma reduction, we try to explore that so that we can see ways to really deal with stigma. I think both with the treatment and testing, stigma is still common. Really, I appreciate that.
That was what you wanted to say. That's okay. So the collaborative piece, like build, that's where like the scale out versus scale up is a big difference, right? Like we were talking about that earlier. Yeah. Yeah, so it's like to build off of the partnerships here and build collaborations with community-based organizations and youth, right? Are there youth serving? Yeah. I mean, I feel like are there youth serving organizations that aren't at the table? Like so I would like, is that an opportunity to okay. Other stuff? Comments? Complaints? Jokes?
Yeah.
Again, this piece of, I mean, for those of you that were doing this at the beginning with us, Jude, Hannah, I mean, the community piece was so important to those of us in the US, wanting me to make sure all of you were at this table. And so it's just, I know we have a lot more to do and a lot further to go, but it's just really happy that you're all here and giving us this feedback. The goal is to try to make this work better. So I shouldn't have said that at the very end, not done yet. And so I'm still open to spring. Well, that was a lot. Yeah, yeah. You're doing great. Oh yeah, we said that actually that engaging law enforcement, especially if we're moving to other parts of the country, has to be part of it. That's an opportunity and a threat. Yeah. Yeah, go ahead. I love that.
For example, I train, implementation science and strategy that for through idea, I train from idea, I train
like capacity building for like learning and education. Especially for key populations. Yeah. This is great. We have over 2 people.
The issues about entitlement they are true. And worsen it by pandering to the wings. Remember we're talking about wings. But you see, between UG3 to UH3, that's what sparked that conversation. We noticed that IDI became, we have the highest number of people linked to care in IDI, even higher than OSS. And everybody started wondering what happened between UG3 and UH3. Now, I think it was because of several factors. But I think it's a whole lot that comes together. Some of the people we have in the testimony are who were working and on the spectrum of co-workers. They saw their work ethic and they started changing in their minds about their preconceived notions about KP members. And then when KP members came, they saw how they were relating with those people and they calmed down. Yes. So people come, you know, if you come to a place and you have a chip on your shoulder already, then you are going to try and bluster your way through and all that. And then they will calm down and they saw that there was a relationship and now we have more people living to care in idea. But it's taking time. The others don't have the experience of UGB, but we went through like this and then went through UH3. But it was a surprise, and I've shared this before now that they are willing to hold meetings in idea. This person didn't want to go to before. So given time, the right and orientation to us both, we might say it's not going to happen fast. But this is the integration we're all working to. At the beginning, but yes, I agree, it can be.
So I think last 3 comments. Please, we'll time ourselves 1 minute. So 1 minute and when
for me, why not trying to make excuses for any form of entitlement? But let's also know that generally, patient providers' attitude is not at its best. We must all admit that whether you are KP or not, some providers' attitude is still a big problem. And again, you don't blame that provider. If a provider has to see 50 persons instead of 10, of course there will be some triggers. So it's not as linear as we think. There are a lot of systemic, and complexities around this that we must diagnose for us to be able to address it appropriately.
While we are struggling to be ready as we receive them, we attend to them on time, I think they should also be addressed that if they don't want to stigmatize them, they should equally put up some attitude. Like, if children come in at the door, they're kissing, they get their seats all over, but they decide to have themselves and all sorts. Already they have created a scene around themselves. Even a couple, a married couple will not come and laugh themselves. So I think, and be kissing themselves in the public. So I think on their own practice, we need to address that.
When you have somebody in that facility that is showing a responsible behavior, other people will latch on to that. So maybe in your own facility, if you need to talk to the healthcare provider, the person may be the one encouraging this kind of behavior that you can just come anytime, you can do whatever you want. But if they see that this person comes early, I still have other patients to see you take it. Over time, let me not embarrass this person and put him under pressure. Maybe that will also help.
Thank you. I just wanted to say something about that. Yes, it's true that it's but apart from patients, pediatricians don't like to send them in time because they feel like you're working so well for many years when they get to
what will happen to them when they get to
but one thing I've noticed is that if you trust, like I'm a family physician, I expect the pediatrician to be able to trust the patient to knowing that don't worry, I'll take care of this person. But
You see how it's like different before they hit 18 and makes it easy. But if your adult curriculum is not solid, I don't want to transfer the child to multiple years for the child to come and die too. The other thing also is from what you said is I was going to say family dynamics and family relations. There are a lot of dysfunction. It's because of my children from like 2005 went to raise my grandparents. So they also from one they don't have, there's a lot of dysfunction. I don't know how to family, siblings, they are not doing like each other. They're not very complex. Sibling has like facets. And honestly, those kids will come to really pick their drugs. I just saw that everybody took like zero. They moved out of the house because of them. Like they can't stay in there. Eventually, the younger one passed depression. And I just saw that girl, I like practically, it took a minute. She was like depressed and hopeless because it was just family. They were closer to some healthcare workers than their family. So it's always good to look at that family.
As we round up, I think can we look at this maybe as the last intervention? Because I think that that's where the peer navigators really come in. So can we say that even if it cannot be of scale for everybody, can there be a program in place where the most vulnerable gets to be attached to some peer, adopted peer, maybe somebody that can play this role? Since it may be something that everybody cannot do or is not ready without incentives, but once we identify some role models, I think it will speak to this mentorship issue. Because we as healthcare practitioners cannot do it for everybody. But somehow, maybe within themselves, we can identify some peers. They've told us that our time is up. We need to hang on. Thank you so much. Thank you.
They don't want to. The executives don't want to leave. I told them now. It's for executives now. I told them.
She said we're done. She said we're done. But
because she had come twice.
Yes.
She said, maybe I should just speak one more time.
Again. Yes, now.
Okay. Thank you. Musa? Problem.
Fine. Yeah.
they are
They are
coming.
standing up. They are not even standing.
And they will come, Sha.
And that is not. What can't we do that?
Yes, now.
Each period can start reporting.
But she rejected.
Everybody doubt it because
Well, I'm sure in the next
just stop our queue.
no. They are taking the last contribution. That's what she told me.
Fine now.
Where's Osa? How are you?
Fine. You don't know me from Ilorin.
I'm trying to place the face. It's very familiar. It's the name that I'm not good with, but face, I'm very sure.
Ilorin. I think you were in Lighton's class now. The year behind.
Jamie Shenio.
No.
What's your surname?
Tolu Afolaran. Afolaran.
Afolaran.
Were you in Lighton's class?
Yes. Majid.
Yes. Lighton, Bode.
Yes.
Michelle,
Yeah.
and all of it. So I'm in class below you.
That's this girl's class. Okuromade.
Ladun.
Yeah. Is that Atinola set, you know?
Arrow, that guy.
It's not okay.
You know, he's not. He has not been okay since. In fact, we used to call him Arrow right from.
Yes, Arrow Magics.
That's everything. I used to see you on the meeting, the calls that we do, and you've been very involved. I'm in Duke, and I'm also in the university. You've been involved in NMA politics, etc. Are you still holding a position?
Immediate part of the show. I landed over in July.
Oh, okay. Well done.
Thank you.
So good afternoon. We'll soon reconvene. We are waiting for the third group to come back. But you know, I did say I was going to talk about the hair. But I think while I was listening to the various groups and the discussions, I think I will defer that and I will share something else when the other group come. I will defer the one for the hair, but I will share another experience that I've had with regards to research and other things. And so we'll just wait for them for a bit and they will come.
Hello? Put me on, though. Ah, okay. Sorry, English is not my language. Sometimes I say things.
It's okay.
Then I realize I said something.
Okay, so they are coming back. Okay.
Oh,
so,
hallelujah.
Yeah.
You're welcome, sir.
So we're giving 10 or 15 minutes to each group. 10 minutes, so that's 13. We will be here. Okay, so we are the last group is back. We'll start now. As they are coming in, I want to share one of my experiences also from the past. You know, when we had these breakout sessions and we're talking, they were doing like a SWOT analysis of the strengths, the weakness, the opportunities, and the threats. But then, you know, sometimes when we dish out information, it is very important for us to gauge the information properly. So at a time, I had to go and take a course outside this country. And as part of the requirement for attending that course, I was supposed to take what they call, I think, 14 modules or 15 modules of sexual harassment course. So I took the first one, I took the second one, I took the third one. So when I finished the 14th one, and I got to the US, and I got to the school, anytime any girl looked at me, I became afraid. Because I'd so much internalized the content of that course that even if a girl was winking to you, I needed to process if it was a genuine wink or something was around it. Then there was an incident that we were leaving the class and a lady was tripping. But because I had read that if somebody was tripping or somebody was drunk or somebody was leaning on you, and there were certain ways you needed to have responded. So I let the girl fall. So the other people now came around, I told you are a bad guy. How could you have let? I say, me, I came from Jos. And my parents, everybody had told me, I can't go to jail in the US. And because I wouldn't know how it will be interpreted if by carrying the girl now, I would say I touched the girl inappropriately. So that brings to fall that when we dish out information and we want to regulate, we should also regulate in a way that it will not be counterproductive. So it is very important. Particularly now we've looked at the IKEA, we've looked at the strength of our interventions, the weaknesses, the opportunities, but we also need to put it at the back of our minds. That as we are looking at some of these things, are there things that we are working or looking at that may be counterproductive? I felt bad that the girl fell, but then I'd rather preserve myself and come back home, JJ, and they won't say Tolu has gone to harass somebody, which I did not have intention. One other thing that course did to me was that every Friday after the course, they will say, let's go and chill out. But me, because I'd already internalized, so there's no chilling out. I just carried my book, put it in my bag, and straight to my apartment. I never chilled out for not one day. So it meant that I'd taken that course out of context. So there are instances where we take things out of context. So thank you so much and welcome back. So we are going to start the plenary. I'm still going to tell us about the hair. But I felt that the one that out of the interactions we've had, I felt that we needed to put information and put intervention and put everything in context. But that one for the hair, I was still going to talk about it. But it borders on consent, the element of consent, and the outcome of inappropriate consent taking. But we'll talk about that later. Thank you so much.
Okay, so who is going to start? So each rapporteur is going to report their conversation to us in 10 minutes. Is that all right? Is that acceptable? Yes? So who do we start with? Chief Executive. The guys in brown. Prof, please, you are welcome. Okay, we start with the young people. The blue and pink, please come.
So the blue group, please.
Dennis, right?
Yes. Okay, thank you so much. We have abandoned the podium for you. So please, it will be good you go to the podium. Don't worry. Oh, no. You're okay.
Okay, good afternoon, everyone. I was told this place is meant for powerful people, so I'm like feeling so nervous standing here because I don't think I have that capacity or strength to be on this podium. But I'm just going to run through the SWOT analysis that the Blue team did. So it was a very interactive conversation among the young people. So I'm going to take the strength first. And some of the strengths for their care program that we talked about is that key populations are the drivers. So it means that in most of the programming that the iCare program is providing, key populations are fully involved in the process. They also talked about providing differentiated model of care, which is one of the strengths of the iCare program. Young people have choices in terms of where to go for services. So they could go to the one-stop shops, which is the OSS, or they could go to the university sites. So we also talked about the fact that we're also involving people living with HIV in key positions, like in leadership roles. We also looked at young MSM patient, helped new MSM patient. So there are a lot of young MSM patients, MSMs to come into care. So that was another major strength. So there's a lot of capacity building around among young MSMs. So we also have, there's a lot of partnership. So partnership was one thing that was so significant, was one of the major strengths, because there's a lot of partnership within universities and other community organizations that they partner with. Okay. So another major strength we came up with was the fact that peer navigators were able to bridge communication gaps. So one of the case studies that was shared was the fact that young people are able to talk to other young people in terms of HIV prevention and treatment, and also where they can get services. So communication was bridged by young persons. Sorry, I needed to. I needed something. Left alone. Okay, so so other strengths we looked at was also the use of social media, especially for MSMs. So we know that there are some key sites where MSMs do a lot of chatting and hookups and other activities, and their care program has also focused on that as one of the strategies of reaching out to young MSMs. Then we looked at the weaknesses. And one of the comments that came out was the fact that the participants in their care program were not empowered. So people talked about capacity building for the participants. They talked about trainings. They talked about education, especially for young persons living with HIV. So another weakness that they talked about was that in a lot of cases, most young people, or few young people, do not accept their HIV status. So when they come for tests and they are giving their result of being HIV positive, they don't agree with the result, and most times they don't agree to enroll into care. So another weakness is the fact that their care program was not able to penetrate some key hotspots. So hotspots, especially places where, like an example was given in JOS, that there are people who act as gatekeepers or as pimps, and they have a place where they have young MSMs that are involved in sex work. So it's so difficult to penetrate communities like that have gatekeepers and also pimps, because the pimp in question do not want a situation whereby you're trying to interfere with the business going on. So as a result, they tend to refuse HIV services when it's being brought to them. So another weakness that was raised was that the iCare program focused mostly on connection to care, but did not include information and support for disclosure. So we had situations whereby some people, young persons, find it very difficult on how to disclose their HIV status to either their parent or their guardian. So also training was also one very key part. Trainings for the participants. It was mentioned several times that not just focusing on healthcare workers or people who provide services for the participants, but the participants also need those education too. So they talked about situations whereby you can provide education programs around HIV or knowing what really HIV is and other services. So also they brought up an issue of the iCare program, having limited representation of diverse abilities. So talked about people who have limited access to mobility, talked about people with special needs. So it was one area that was not focused on by the iCare program. And also limited geographic availability of programs. So we know that the program is not cut across the country, it's only in specific places. So one of the weaknesses that was also mentioned in the group that participants were not provided with mobile phones. So there are some regions where it's so difficult to reach the participants, and suggestion was made that if they have like mobile phones, they'll be able to reach the person. And examples were given how they've been trying to reach some participants, but because the person doesn't have access to a mobile phone, so it's hard to reach the person. And also plan for sustainability. We know that this is a project that has a number of years attached to it. So people are looking at it from the area of what happens after the project ends. So what happens next? Then also the area of text messages. So we looked at a situation whereby some participants in the project might not have the resources or the financial resources to send messages or make phone calls, in the project. Then some of the opportunities, now moving on to the opportunities, sorry we have a lot. Some of the opportunities that were mentioned that was to work with gatekeepers. So we looked at areas where gatekeepers are very strong, and with the opportunity there was to involve gatekeepers in the programs, probably train them and provide them with the necessary trainings in order for them to be able to reach their peers, because we believe that these gatekeepers have strong hold of their communities. And we also looked at the fact that some of the weaknesses are site-specific, because we had instances where the Ibadan team said they have a mental health program that is going on, but in another site it's not that. So there could also be some room for learning and collaboration and see how that works out. So another major point that was raised was to train healthcare workers to be KP friendly, healthcare workers to be key population friendly. So in most of the sites, the iCare program work, we expect that more healthcare workers will be trained to be KP friendly, so that is when KPs come to the facility, they won't feel judged or discriminated against. Another opportunity we looked at was to make mental health a priority. So mental health is something that has been growing very big in Nigeria now. In the past, we usually don't talk about mental health. There's always some cultural beliefs about mental health issues in the past, but that has been gaining ground now, and we realize that mental health is really a very big deal in Nigeria, that young people also have mental health issues. So we need to make mental health as one of the priorities too for the project. Also, create more awareness of the uptake of PrEP among young people was another opportunity that was identified. So another opportunity that was also defined was, aside from the fact that we provide care and support for people, young people living with HIV, they also want a situation whereby the project can also support participants in the project to achieve their life goals, not just focus on just the HIV alone, also look at what this young person wants to achieve in life and also see ways where they can do that in achieving their life goals, which can be in terms of skill building, building their skills on some income generating activities and other services. So we talked about building in educational program and support, having a toll-free line. So a situation whereby a young person is trying to call, the call can be for free rather than being charged, because we've also identified that finances is also one of the major challenges faced by young people. So they might find it very difficult to make calls. So if the program can have like a toll-free line where young people can call in for free and also access the services they want. Then also we looked at engaging law enforcement agencies. So one of our colleagues mentioned that in their care program, they've not noticed any engagement with law enforcement agencies. So it is also very key that we engage law enforcement agencies in the activities that we do or in the program. They also looked at diverse strategies that are specific to KP programming. So we looked at the FSW community, young persons who use drugs. So there are young people who use or inject drugs. So we also looked at the fact that we can also focus on this group of young persons. Okay. Then I'll move to the threats. I'm almost done, sorry for the time. So for the threats, we talked about sustainability, what happened next. We know that this is a project that has timeline. So after the timeline, what happened next? What are the sustainability plans? So that's one of the major threats. We talked about the legal framework, especially the same-sex marriage prohibition bill in Nigeria. We saw that as a huge threat. We also talked about safety to staff providing services to KPs. We believe that the healthcare workers or the staff that provide services to KPs are also at risk too. We looked at high mobility of KPs. So it is known that key population, especially the MSMs, are highly mobile. Extremely mobile. You might meet a key pop in Ibadan today, and by the time you are calling the person to come back for medication or treatment, the person is already in Abuja. And by the time you are calling again, it's already in Calabar. So they are highly mobile, which we also noticed that is also a major threat. Then also we looked at the technology used by the iCare program. We agreed that it wasn't providing all the necessary services as needed, so there's room to expand more on the technology. Someone also raised an issue of attitude and stigma towards people living with HIV, that is still a big deal today. There's this stigma, in the community. Then we looked at influence of poverty, especially in rural areas, which is very difficult, because we looked at using social media as a means to reach young people. So we looked at people in the rural areas, for example. How do we get across to those people in the rural areas that might not have access to these technologies? Then finally, we looked at next steps. So what are those things we want to see? The key points. So we talked about expanding to other parts of the country, not just focusing on the few locations they are right now, but expanding to other states in the country. We also looked at focusing on the third 95, which is viral load suppression, which is one of the major challenges I know that a lot of projects is facing, because we saw from our presentation today that we are still not at 95. So we feel that should also be a priority area that the project needs to focus on. We looked at coming up with more innovative approaches for stigma reduction, and finally leveraging on existing collaborations. So we believe that there are other CBOs that are already providing services in the country. It would also be great to leverage on those CBOs that are also providing similar services in the country. Thank you so much for the time, and I hope I did justice to Team Blue. Now I can go.
Yes.
Okay, thank you.
So thank you so much. So we are going to take the next group. So we leave the elders for the last.
Yes, we leave the elders for dessert. Let's have the second group, our healthcare providers. Dr. Kuti. Yes, you're welcome.
Good evening, everyone. We had our discussion, essentially, yes, healthcare providers, essentially the PIs and the co-PIs of ICARE Nigeria. So we didn't exactly do a SWOT analysis, so I think they moved all the stuff, but the approach we used was to look at, our work so far and kind of evaluate what we kind of achieved, what I experienced. Actually, that was the question the moderator put on. What was your experience as healthcare providers or as PIs and co-PIs working with the ICARE interventions? So we discussed treatment and testing, and before we knew it, our moderator told us time was up. Well, we'll tell you how far we've gone. So we then also looked at the challenges and like strategies going forward, since we are the ones implementing this. So we looked at the treatment arm of our project, and part of the experiences that people shared across, we had people talk from the different sites, was how the peer navigation really improved bonding amongst the young people living with HIV, or the youth living with HIV that we engaged, and their peer-to-peer interaction. We also had the opportunity of having a professor of child and adolescent psychiatry in our midst, who quickly brought us into like perspective to say that young people generally, adolescents generally, we know that they are not big babies and they are not small adults. They're just entities of their own, and they have their own peculiar needs, including, of course, development problems and mental health issues, not because they have behavioral problems, but because they're just generally trying to adjust to life. And that some of these adolescents, health-seeking behavior, health is not a priority for them because they're adolescents. So having to make them, take responsibility as well for their health could be an issue. So on that background, based on the experiences, people felt that really increased peer-to-peer bonding, which we know that for most adolescents or young people, some of them may not want to talk to their parents. They may feel more, at ease talking to their peers. We also identified, there was a co-PI that said that it made them identify silent challenges at their sites, and in asking for examples of such challenges, like they had a peer that was contemplating suicide, that they had to provide mental health services for, who is fine. They had things like someone contemplating abortion, people say, I'm like homelessness and all of that. So some of the challenges that were just silent, that we didn't, it wasn't like we went out to look for them. And I think the good thing about the ICARE study for us is that needs assessments we had, which even though we were doing research, we actually had this social aspect of it, because we knew there's some things that could affect adherence, like social support and family problems. And then it was some people said there was some form of like mentorship for the healthcare providers, like they provided mentorship to the navigators and even some of the youth, just because of that program. There was just some sense of like bonding that they had. And then it also kind of gave a lot of these peers hope for the future. So it's kind of like a strength, but it's part of what we achieved. Now for the challenges, and they're numerous, I would run through them. The background that we also identified from a lot of people that have been healthcare providers of this youth when they were children, is that there's been a problem with transitioning to adult care. So when you have a young person who you are saying use your medications, reply SMS, and take responsibility, whose parents have not really like fully disclosed to, and they're just trying to figure things out. It's not as easy as just saying, well, get the SMS and reply or talk to your navigator. So that's problem with transitioning to adult care was one challenge. And then financial. So these are children, well, I don't want to use the word children because a lot of them were children, I was taking care of them, but these are young people who, they don't earn money. They are not income generators. So anything you have to do with them is dependent on other people, like their parents and caregivers, whose interference was another form of challenge. So you might have a parent saying, I don't want you calling my peer, or I've seized your phone. You can't you can't reply to the SMS, and then we also identified problems with like difficult participants and poor social skills among some of his participants, where they will just straightforward tell their peer that don't call me, I don't like you calling me, I don't like receiving calls. Or some of them even bullying their peer navigators and saying, if you don't send me credits, then I won't pick your call or I won't answer to the SMS messages. For phone issues, some of the challenges we also found were that these young people were exhausting their credit. So we're giving them 400 naira every month to like reply the SMS, automated SMS, but we understand that most of the time, and it was unanimous across sites, that they were exhausting their credits because they would have borrowed maybe credits. So someone had to actually say that, let's separate the Nigerian factor. Like, it's not because they're adolescents. This happens to like most people. You'd have borrowed credit, and by the time you're supposed to respond, you won't be able to because you're in deficit. And then we had also issues like the peer navigators themselves, or even the peers, coping with life events. So some of the navigators had to be pulled back for other people to take their place because of life events, or coping with just entering school themselves, or things happening in their families, or ill health, and not being able to cope. Phone issues, like I said, apart from the credits, seizure of phones, some of them overexcited and taking their phones to school, and it being seized and them not actually being able to respond or get their navigators to reach them. And then, okay, so we've talked about lack of parental support and understanding for some of them. And then nutrition was a key one that we talked about. As I don't want to say insignificant as it is, food insecurity is a major problem, where you have adolescents telling you that I have not used my peer. The navigator is saying this peer has not used their drug for 1 week because they don't have food. And you're like scrambling and running how to like get food across maybe to them in school and all that. So that was a major challenge we also faced. Then family dynamics. So it wasn't just about saying the parents should be supportive or the caregiver, but we also realized that a lot of these young people, apart from, being in eye care, just young people living with HIV, had a lot of came from like dysfunctional family settings and poor family functioning, where maybe they were, grandmother-led households when they were babies, and there's no grandmother anymore, so they are hopping from one caregiver to the other, and some may be supportive, some may not be. And so it depends. So trying to engage that kind of person and saying peer navigator, especially if it's someone you've not known before, and you want a young other person to navigate you, there were some challenges in that regard. Of course, mental health, really key, substance abuse, which just complex interplay between like family situations as well, which could have led them to use substances as well. But we had some challenges in that regard. But thankfully, like he mentioned, the person before me, some sites had the mental health already in their facility. Others had to like co-manage some of their care participants with health professionals. Yes, so for strategies in quotes, or like recommendations for us going forward, part of the things we talked about, of course, was adolescent and youth friendliness of our facilities. Not just for, healthcare, what has been nice, but providing things, like someone gave an example of having like things like table tennis and, TV films, while during clinic, while they're waiting to see their doctor, engage and just relax. They're young people, nothing uptight for them. Just make them relax and make your clinic adolescent and youth friendly. Integration of mental health services going forward for those facilities that don't have. And then socioeconomic support. So from the government now, and I know that our elders are going to talk afterwards, but it's something really important to consider. And I know I gave an example of a family we had siblings whose mother had died of HIV, whose father had remarried, living with HIV, but eventually both of them moved out of the house. They were coming to clinic and picking up their drugs, but you could see that I really love that fourth goal, 95. I put it down in my diary and I was like, health-related quality of life. Because I'm trained as a family physician and I think it's easy to say, oh, adherence is 95%, but the quality of life of these young people, I think for ICARE, that's one thing I know Professor Rob always says in terms of like the impact that ICARE actually has in the lives of these people. And then, so the last thing we talked about was that in scaling up, and we didn't talk so much about scaling up because we'll talk about that tomorrow, but we did say that in looking at the other regions, South, Southeast, where we're scaling up to, that he asked the question, and I really liked that. He said, would there be, regional differences if we look at Jos and look at Ibadan? Or if we even look at Ibadan, which is more conservative than Lagos, or compare them to the Southeast, would we start seeing differences in like the ICARE interventions? And we're proposing in terms of strategies now to say that before we scale up to that, we really need to like adapt the interventions in each of these new regions and not just take it, because there just might be differences that we need to compare. So quickly going to the testing arm. I hope I've not run out of time. Some of the, of course, like you said, and I won't say too much because the youth and CBOs have said this all, it's the fact that we really leveraged on social media and peer navigation, moving into the key populations to test a lot of people and got a lot of people linked to care. Of course, it did come with its own challenges, part of which was bureaucracies at the treatment sites. So a lot of the participants didn't want to come and register in the big hospitals. They preferred the one-stop shops for many reasons. Stigma and discrimination, attitude of healthcare providers, and those facilities themselves not being, would I say, KP friendly. But the other challenge we also noticed, apart from the background, national background of the MSM being, same-sex, act being illegal and all of that, and the criminalization of some KPs, is that a lot of the providers actually talked about a sense of entitlement from KPs, that we just kind of need some middle ground. At times, some of the KPs come to clinic feeling very entitled. They come late to clinic and they just expect that people that have been sitting down there since 8 a.m. waiting, elderly people, young people, I can't wait, I'm on a fast track, let me go or something. That those are some of the challenges in trying to provide care. And then, yes, so those were part of the things we noticed. And then for strategies going forward, we did recommend, or we're looking at seeing how our facilities can be more KP friendly. And someone talked about sexual diversity training for all staff, all healthcare workers, from the receptionist down to when the person gets to the doctor, the entire facility. And then management of KPs integrated into the clinic care. And then most importantly, engaging the government, I guess also with data like this. Someone here today talked about writing proposals and at least having preliminary data to present. And yes, so the other thing you said too was that in terms of strategies, there's a need to educate KPs in having realistic expectations. That yes, we know that you have needs and all, but try to get to a middle ground with the healthcare providers because they really want to help. But when some people come to clinic and show overt affection, that someone said that even married heterosexual couples don't, you're just all over the place being overtly expressive, that even already makes people, act negatively towards some KPs, but that, that middle ground is really important for us to know. And Dr. Adetunji in IDEA also shared with us very importantly that in UG3, a lot of people that we tested wanted to go to OSS, but by UH3, a lot of them are coming to IDI. And for so many reasons, we're actually looking at that ourselves. And he's tried to encourage them, say, over time, things would change. Part of what he talked about was the fact that the KPs working with ICARE, are responsible. There's a lot of professionalism, and then even the non-KPs staff in ICARE that they are working with, there's a sense of like relationship and family, and so even if you are coming to like brag, you kind of count down like everybody here is, it's all about love, and we're a family in quotes trying to achieve a goal here. So that's how far we could go. Thank you.
Thank you so much. So, can we applaud Prof? And
thank you. So, the third group. Is that the first group? I didn't know about that. I thought we were the third group. Anyway, the people we had in the house are government people. All the NACA, SACA, SASCAP, head of program, implementation or high peace, the WHO, the UNICEF. Those are the people that we have in the hall there. And we discuss policy issues that we think will impact on adolescent health, using the same formula that everybody had used, the SWOT analysis. And the strength that came to table in adolescent care is that in country we already have a number of infrastructure in place. In particular, we have here and there adolescent-friendly clinics, which are already existing, and we think that is some strength. In addition to that is the availability, that we are not in short supply of policy documents that guides adolescent care in the country, is considered as strength. And then in support of adolescent health and adolescent health care is the fact that we now have a number of differentiated service deliveries that is more adolescent friendly. You get to the clinic, you have a special adolescent clinic, like a Saturday clinic, afternoon clinic, all to support, to make health services more available to the adolescent. And then we also discuss that multi-sectoral collaboration on non-health sector responses is also helping to improve healthcare services to our adolescents, like the Ministry of Youth and Sport, making outdoor facilities available for our adolescents to go out there and fully express themselves. We also discussed the fact that we already have in place some support groups and adolescent clubs that makes adolescents coming together, expressing themselves a lot easier. And then there's also the availability of what some people tagged as psychosocial support helplines for adolescents. They can go online and give some support for themselves in terms of their health needs. And of course, human resources for health was also considered as a strength, that we now have a lot of people that are already being paid by the government of Nigeria to provide adolescent health services. These are what the group considered as the strength in support of adolescent health care for the country. And now there are a gamut of weaknesses. Most of the things that they listed as strengths, they also considered as weaknesses. For example, they are talking about adolescent-friendly clinics, and the question was raised, are those clinics existing by nomenclature or by function, and that is a big issue. And then the age of consent became a hot topic there, that the adolescent is not able to consent to start treatment or to participate in research is actually an issue. And it was discussed that some adolescents still don't know their status, and they're just consuming antiretroviral drugs. And of course, when they get to know what happens, it has some counter-productive effect, and they may actually stop taking treatment. This is regarded as a very strong weakness. And then we talked about parallel programs. You have 2, 3 implementing partners coming to the same facility, and of course, implementing the same program and collecting the same data or duplicating data that doesn't doesn't allow for the best use of the little reserve of the health manpower that we have. And then the group discussed at length. I didn't contribute to, I was just listening to them. But it was, I consider, heart-to-heart talk on that table there. They were talking about relationship between NACA and SACA. Are they duplicating effort? Is there not a need for us to have one reporting line? What can we do better to ensure that our energy are harnessed and we're better able to deliver services to Nigerians as a whole? That was a very hot topic. Then it was stated there are few. Okay, I think I've stated that. Somebody discussed to us and said the response to HIV/AIDS care is considered as a bifurcated response. Bifurcation in the sense that, okay, you have, I think that was actually the genesis of NACA-SACA debate. You have a situation where somebody want to run this program, another authority want to run the same program, and then you have an issue in who is actually the superior. I think they proposed a solution to that anyway, and I'm going to tell you what. Let me just tell you straight away. What they said in that regard was that there's a need to establish a line of report by law. And if I cannot get it done by law, let there be mutual understanding among the IPs and among the different sectors that will be implementing this program. And they cited places in country where this is already happening. They cited we have real collaboration of such understanding in the practice of HIV program in Akwa Ibom. And of course, I think in Kano, they said there's a special relationship there where you are, by law, there's one reporting line, whether it is SACA or NASCAP, whatever it is. That one is established by law. But we have a few states where there's actually a mutual understanding where NACA, SACA are working very effectively. One other important weakness that was discussed is the fact that although we have clinics all over the place, adolescent clinic all over the place, OSS out there, but the staffing is very, very inadequate. And of course, remuneration for the staff that is provided these services are either also inadequate or not there at all. And they cited one state in Nigeria that has not been paid, whose health workers have not been paid in the last 1 year. Should I mention the state? They said it is Habia that have not been paid in the last 1 year. And that actually was shocking news to me. I was just listening to you, but you don't know, I was depressed listening to those stuff they were discussing. Now, another important weakness that was discussed is the fact that we do not have sufficient data to inform policy. Where data are coming from, it doesn't get to the center where it's supposed to be used to inform policy, and that we have a lot of missing opportunities in data collection in Nigeria, in several private hospitals that are providing HIV care-related services that are not being collected, and many laboratories are out there in Nigeria that are providing a number of tests related to HIV services, and the data are not being collected. And these are actually regarded as weaknesses that really need to be looked into. The last weakness that was discussed is that we agree we do not lack policy documents in the country, but are we actually looking at these policy documents, and is there actually a need to have to update some of the information in these policy documents? I think that was also on the table, that a number of policy documents are probably outdated, and then there's a need to have update. What was considered as opportunities in the SWOT analysis is that we have multi-sectoral collaboration. The Ministry of Youth Development providing outdoor facilities for the youth to express themselves. We also have adolescent programs that has already been implemented in the country. They mentioned Operation 000, they mentioned Viral Load Champion. These are actually existing activities in the country that is supporting adolescent healthcare services in the country. And they also mentioned the fact that we have access, for as long as it will last, we have some access to funding to support HIV program as a whole, but we can draw from it to support adolescent-specific exercises, particularly UN funding and PEPFAR funding. These are what were regarded as opportunities. What were the threats that were discussed? Number one was the fact that it was stated by some people that financial gains appears to be the push for some actors out there to pretend they are doing adolescent program. What is in there for me? And I captured that and was like, can that be true? Well, that was a big threat to the program. The other big threat that was discussed was that the need to deliver on some targets, because when they are doing programs, it's always target-driven, and then you want to reach your target because of your funding. It may compromise a standard of practice. That was regarded as a big threat. And then, of course, one other big threat is the fact that you have an IP who decided to do good and put infrastructure in place, but other IPs come and not able to maintain those infrastructure. I think that is something that we should look at. And one thing that was discussed when we were about to leave and they came to drive us out was the fact that there was cutting of funding for what they call family life and education. I'm told, I didn't know about it before. They said family life and education is a funding to the Federal Ministry of Education to begin to teach children in schools and secondary schools stuff about HIV and AIDS. That funding from wherever it's coming is no longer coming, and it's actually a big threat to enlighten the youth on the subject of HIV and AIDS. And then one other big threat that was discussed is the faith-based organization that don't want to hear anything about key population, don't want to hear anything about use of condoms. These are the major things that were discussed as the threats. And then the last thing that we discussed, what can we provide as some solutions to a number of the issues that have been raised in the SWOT analysis. And there are just 4 things that they discussed there. There's a need to have to restore the family life education, wherever that funding is coming from, should look at it again. And then there's a need to have to improve the coordination of HIV program among the IPs. You cannot come into the same hospital and be duplicating effort. There's actually a need. And of course, the SASCAP or NASCAP in the state are supposed to ensure that the IPs are actually, IP, implementing partners, do not duplicate effort, and then you can let them concentrate in different program areas. There's a need for that coordination to be in place. And of course, the other one is that there's a need to look at best practices in some states and let other states copy it. And they cited what is going on in Akwa Ibom, where NACA, SACA are working in coordination and synergistically to improve the healthcare program regarding HIV/AIDS program in that place. And we are told that there's actually a need for some other states to do what they call peer learning. And that is going to help us a lot if we try to bury our, we don't swell, just go and learn it where it is working. These are the issues that were discussed at the meeting of the SASCAP, NASCAP, the UNICEF and WHO attending our meeting. Thank you very much.
Thank you, Prof. Thank you. Would there be any comment or questions to any of the rapporteurs that reported now? Before then, I have a comment too. I heard one of our doctors saying that their clinic is so KP friendly that other patients feel at disadvantage. So I think KP friendly is also a sort of discrimination. Why can't we just be friendly? Probably the person that has come to your facility needs help. So let's just be friendly, fair, and objective. I mean, so there won't be any questions, I understand? There is, of course. All right. You have a younger and more beautiful girl attending to you.
It's okay. I'm also young and handsome. Available, single, and still searching.
She heard you.
Okay. Those are beautiful presentations from all the groups, and I think there's a lot to learn, both about the iCare program, as well as the potential opportunities that we still have ahead of us for scale-up, diversification, integration, and all of that. I was just thinking, sitting here, and I had a couple of chats, over break, and I was saying that we're discussing about the fact that despite all of the challenges that we've had in the country in the last maybe 10 to 15 years, specifically for key populations programming, looking back, I think there is every reason to still be grateful for how we have evolved over the years, where we are today. Because over lunch, we were saying that this kind of meeting maybe 15 years ago would have been a very tall order. Maybe in one very closed space somewhere that you have to keep watching your back and all of that, but here we are. And over the years, we have become very comfortable talking about MSM, talking about transgender, talking about, there were times where even government officials were denying the fact that we don't have MSMs in the country. So I think for me, just to give kudos to those who have, engaged, and not, allowing themselves to be discouraged by some of the challenges that we faced. Then the two things, one of it is the fact that even for faith-based organizations, I was also telling the folks that we sat at table with that around, I think 2009 to 1999, 2000, I had packs of condoms in my hand during a World AIDS Day program, and I was refused to enter a vehicle because the vehicle belonged to a faith-based organization, But today, that faith-based organization is implementing one of the biggest key populations programs in Nigeria, which for me is also something we should be grateful for, because that's some level of appreciation of the fact that there is so much diversity in our humanity that we need to, even if you don't understand it, just appreciate it and let it be. The last thing I will say is that we don't know how long this would continue. Therefore, we should take full advantage of it. Programs like ICARE, all the others that we have mentioned today, all of the government, please look at the government people very well in the room. They are your allies, especially the community members in the room. Because earlier on, I wanted to speak, but I was denied. There is a lot of opportunity, even in those grassroots areas where you think if somebody is picked up, he will spend weeks in. No, it's not. It's no longer like that. You need to identify the networks. They are there, they are available. It's just for us to identify and make use of them. The National Human Rights Commission, we've not been able to use up to 10% of the potentials. They are begging for reports. They are begging for cases. They are begging for, they want to know. And they have granted justice to a lot of cases that have gone to them, including compensation to people whose privacy have been violated, whose rights have been. So I think there is a lot that we need to network, share information about, and I think the future holds a lot to offer as far as HIV and other public health intervention is concerned. So well done, everybody. Thank you.
So thank you so much. We are getting close to the end of the program for today. But like I did promise that I was going to give my experience about the hair stuff. So I'm going to take it now before we close. So I'm sure we know that, and we know that in responsible conduct of research, there are two main things. One, the researcher's obligations and the participants' rights. The participants' rights must be protected. And we know one of the key things around it is the concept of consent, voluntariness, lack of coercion, and also willingness to participate. So we had this guy who wanted, it was just, when you want to conduct research, your blood is hot. You just wanted to do research. You wanted to publish. And for most of us, your first publication is like your first baby. You just be happy. So he had his friends in the university, they are publishing, so he wanted to publish. So he wrote his protocol, he got ethical approval, he was going to collect samples in some local government, general hospitals in some local government outside town. And, as part of protocol, IRB approval, you submit your consent form and all of, so they approved all of those. And he was going to do nutritional assessment. So he was going to take blood sample and take strands of hair on the 5s. So when he got to the facility, he had done proper community entry, had gone to the facility, but he forgot at the point when he was seeing the children to make the parents feel the consent. Because he had just spoken to them, and we are going to see your child. If your child is not feeling, your child will take care of your child and blah, blah. So he was taking sample, collect blood sample, taking 2 few strands of hair, collecting. So he did, and towards evening, then we saw a lot of youths coming from the community. This guy today will see pepper. This guy today will see pepper. Me, being who I am, I'm a gentleman. I had already gone to one corner. They won't even be able to associate me with that guy. So I was just in one corner. I said, this guy will see pepper. This guy, I was just looking at, okay, we'll see what will happen. So when they came, apparently one of the women had gone home and I told the husband that today we were treated very well in the hospital. Even the doctor even picked some strands of hair from your daughter and blood. The man said, blood? Rituals. So he left the place, went to the youth leader's place and mobilized some youths. That today, that guy will return all the blood sample and the hair because all the children would die. So when they came, they started battering, started shouting. I was just wondering that which kind of wala. And there was me, I was still a very young resident that was just trying to find my level down. So this guy today will see prepel. So eventually, when they came, they dragged the guy. They wanted to start lynching the guy. Then the head of the facility said, okay, what was the problem? He said he took their blood, the blood of their children, and the hair strands. So the guy said, yes, he did, but he explained to them, and they agreed. So the husband said, did my wife sign anything? He said, bring it out. That was when we even knew. You know me, I was a research assistant. And me, once Wala started, I had already tissued to one side. So, bring the consent now. The guy couldn't bring the consent. But because he had done appropriate community entry, so the community leader knew about it. So when it became a lot of problems, the community leader came and now addressed the people. So they allowed everything went down. But the rationale behind the story is that when we want to do research, we should do research the proper way, because it may backfire on us. And one of the things we've learned from participation in IKEA is that the IKEA project wouldn't take this for granted. As you are reviewing the protocol, you are getting another IRB approval. I'm sure George and the others and Madam Titi will know how many IRB approvals we've gotten. And so it is important that we leave this conference or this workshop knowing that when we are conducting research, there's a lot of responsibilities on us as researchers. Thank you so much. So we'll be closing, and we are going to call Prof.
I believe there's a comment, last comment from that table.
Thank you very much. I thought I've lost the chance. But then I want to quickly, in our group we discussed about policy, and I think I need to say this before I leave. You see, disclosure is something that we need to take very seriously. Many schools do investigate, they do some investigation on students that are just coming in. And in many schools, HIV is one of them. And by the time the result comes out, it does not come to the client. It goes to the management of the school. And it's causing a lot of trouble in my state, presently. So I think nationally we need to look into that. I don't want to bore you with all the stories around it. This is a university. But there is this other lady in another school, still in my state, who had been previously abused by his father. His father is late now. He died of complications of HIV. And the girl became positive. And she, of course, she kept it away from other students. The family brought her to Oyo State because of her status. They didn't want her to school in Port Harcourt. So here, she fell sick. They took her to a private hospital. Of course, they got the result, and they sent the result to the school. And everybody in the school knew her status. And it became a very big issue. I mean, open discrimination, open stigma. And of course, we had to come in. We brought in Ministry of Justice, brought in every other, We were there at the school, in the university. Obviously, we realized that the VC and other management staff acted based on ignorance. And we had to bring in, luckily for us in the state, we had anti-stigma law, we have this and that, so we had to educate them, and they apologized profusely. And we asked the lady if she still wanted to continue our education there. I don't let me bore you about other things that happened, but at least we were on it. But what I want to pass across is that when we're talking about stigma and discrimination, we always think it's all about health workers, health facilities. But what is happening in our schools, about disclosure, about the laboratory, we need to look into it. Thank you very much.
So thank you so much, sir. I think this further also corroborates my last talk about getting consent. When people are going to be tested, they need to consent to testing. And it's part of some of the things you do at pre-test counseling as also at post-test counseling before disclosure of results. So I think it is important that we all as researchers put that at the back of our minds. Thank you so much.
All right, thank you, Prof. The mic is yours.
You're not clapping for me. No, I have to collect my clap. Yes. No, but seriously, thank you so much for a very productive and engaging day. I hope that everybody here has learned something. I've learned a lot. Be rest assured that a lot of the things that we heard from you we're going to digest them and we'll figure out ways to incorporate them as we're thinking and expanding our work. We hope that you will continue to be part of this work. And after a very long day, I hope that you'll have some time to relax. The next item is going to be at 6 o'clock. There will be dinner. So I hope that all of you will turn out and participate in that as well. So thank you so much, and I look forward to seeing you later today. Bye-bye.
So please, can we kindly pick our folders, the program, the conference program, and take it with us, because tomorrow we are going to return and use them. There won't be another one provided tomorrow. Okay, the venue for the dinner. Yeah, it's here. So we'll be coming back here by 6 for the dinner. So please, can we go with our jackets, our folders? Thank you so much.